Hi everyone, welcome to session 11. Sorry again I wasn't able to hold class on Tuesday. Today we're talking about, or I should say for this week, we're talking about access to medications. And for this lecture, we're just going to talk about some of the different approaches to increasing access to medications. If we were in class, we'd spend a lot of time with me kind of asking you about the different approaches and going back and forth on the pros and cons of the different approaches. But since I'm doing this online, I'm just going to try to point out some of the pros and cons. And if you have any questions, just email me anytime and we can talk about them, or you can ask questions next Tuesday when we meet up also. All right, so the first issue is, why do we have a problem with access to medicines? And this lecture mainly focuses on access problems in developing countries. We also, excuse me, sorry, we also have access problems, but and we talked about some of those, obviously with uninsured people and so on. But we have a fairly good array of policies that try to address our access issues. However, in developing countries, those policies don't exist, or if they do exist, people are so poor and the countries are so poor that the policies really don't matter. So you can say you have national health care, but if you don't have the money to really offer it to people, then what's the point? It really doesn't make any sense. It's not really effective. So, 1/3 of the world lacks access to medications they need. As a result, some people are actually dying because of lack of access to medications, which is not a surprise for any of you because of you're in public health. There are a variety of reasons why. One reason is just that people aren't doing research on the diseases that are impacting these individuals, so they have what we call neglected diseases. They have diseases that we really haven't, as a species, spent enough of our resources trying to understand and trying to develop technologies, including drugs and so on, that can actually prevent people from dying from these illnesses. So we do need more research on neglected diseases, and there are some pharmaceutical companies like Novartis who are actually trying to do R&D in this area. And we used to have a scholar here at GW by the name of Peter Hotez, who was doing a lot of good work on neglected diseases, and is a well-known figure in that area. And actually had a vaccine he was working on for hookworm that was really focused on a neglected disease, and it's really good work. And so some companies are getting into this. Obviously, a number of nonprofits are interested in this area because people are dying unnecessarily just because we don't bother to spend time researching the illnesses so that we can perhaps treat them. All right. In some cases, as I already stated, people can't afford the medicine, so and that applies to countries and it applies to individuals. So as a result of not being able to afford the medications, then they're not available, right? They're not accessible because of affordability. Also, in some cases, people would live in areas that are just hard to get to, and those people are not close to any healthcare providers, so distribution problems might exist so that we can't actually get the meds to them. And thinking creatively about ways to distribute medicines and other types of goods to these individuals is a challenge. And as we talked about in the last class, there may be quality problems and concerns that are arising because um, companies may actually be manufacturing drugs, but the countries don't have the regulatory systems in place to prevent the manufacture of unsafe drugs, drugs that are low in quality, ineffective, and so on. So people are suffering from a result, and they're not actually getting the medications they need. They're getting the wrong thing. Um, then in some cases we have things like packaging. So there's low literacy in general in some countries, so that people can't actually read cannot read packaging, and then there may be low health literacy problems that prevent people from understanding what labels say even when they can read. They may not understand side effects, for example. All right. So I gave you this report on access to medicines. It's by a foundation called the Access to Medicines Foundation, and they really spend their time trying to push for companies to engage in efforts that increase access to medicines worldwide. And you can see that three of the companies in the top 10 are from the United States. So it says we're doing okay in this area. We could be doing better. The top country is not from the U.S., and there are a number of other countries here that you see that are not U.S. based countries. So we are working to do better in this area, and probably in the future, hopefully, you'll see more U.S. countries in the top 10. The foundation uses a variety of different approaches to evaluate whether or not these companies are engaging in efforts to increase access to medicines, and they look at seven main factors. They look at management, the company's relationship with policymakers, research and development, pricing policies, policies related to intellectual property or patents, licensing, and so on, and any support they give to developing countries, efforts to distribute drugs and monitor the effects of drugs being distributed in their countries, and also they look at the philanthropic efforts of these companies in order to decide whether they're engaged in philanthropy that might increase access to medicines. All right, so in class, I would have then asked you, well, what are these companies actually doing based on the reading, and we would have had a little give and take on the different approaches they're using. So one approach that they're using is at the management level. Is that some companies actually have specific departments that are focused on getting drugs out to needy countries and needy populations. So, for example, Glaxo has a developing countries and market access division. And they also, within that division, they incentivize their managers to focus on increasing the volume of the drug being distributed instead of focusing on profit. So you might wonder why focus on volume instead of profit. Well, in the case of large countries like China and India, volume will actually give you a similar level of revenue as selling your drug at a certain price. So the companies are figuring out that, well, we don't actually have to sell our drug for $200 per month in China. We can sell it for $50 and get the same or more money, right? So in those cases, the companies really want to push for more volume, and they want to push their managers to find various ways to market their drug, get it to people, distribute it well, engage in a variety of different innovative approaches that lead to the drug being distributed well. And sometimes that might lead to, that will lead to a lower price because they're really trying to make their money off of a volume. All right, and the incentives I just talked about. So, another thing that companies might be doing is engaging in R&D that's focused on the diseases that matter for the countries who really need these drugs. So, that might be anything from studying new malaria treatments to finding better ways to address side effects of TB drugs, for example. So basically, doing more R&D on drug diseases that don't really impact the industrialized countries a lot, but they really are important and matter for these low-income countries. Another thing these companies can do is just to simply lower their price. So that's what they might do if they're increasing the volume they're distributing, but they may just do that because they know the country can't afford their drug, and they can simply lower their price. Lowering their price would allow them to obviously keep their patent protections on the drug. They would lose some revenue, but it may be worth it because of the good PR that comes with offering a better price to certain countries. All right. Another approach you can use or that companies use, is tiered pricing schemes. So this is when the company decides that, hey, here we have a country where we have a small percentage of rich people, and then we have a huge amount of poor people. So most of the people in that country can't afford the drug. So, but some can. So what you need to do is tier your pricing. So you have a pricing for all these poor, lower income people, and then a different price for the higher income people. In some of the countries that are have a growing middle class like India and China and so on, the company can actually tier their price even more, come up with three major prices or some other combination of pricing of prices that they want to offer. And these pricing schemes can basically attempt to get the drugs to certain people at the proper price. An example is if there is some village pharmacy in a low income country, and the village pharmacy might offer the drug for a cheaper price, but if you're in the inner city area where people have more money and they have more middle class and upper class people, they may actually offer the drug for a higher price there. So that's where you can potentially see these tiered pricing schemes at work, and countries like these because they're one way to get the product out to lower income people in their countries. All right, and another approach is repackaging. So companies can actually engage vendors in these various countries so that they then basically share some of the profit and revenue they're getting from these countries. And also, these vendors help with translation, packaging things in a way that people really can access better, and so on. All right, there are a variety of different policies that the companies can have in place, which can impact whether or not they are pushing for increased access to medicine. So they can have policies that prevent lobbying practices that may be harmful to increasing access to medicine. So, for example, the company could engage in lobbying that leads to a health minister favoring strong patent protections. Well, that's great for the company, not so great for access to medicines, and that's likely to increase the price. So, the Access to Medicines Foundation would like for companies to have policies that are not favoring really stringent patent protections. They would like for them to favor or have policies that favor things like voluntary licensing or coming up with tiered pricing and so on. Transparent marketing is another area. So companies should have policies in place so that they make all of the information they're using to market available to a country or to the public. They should not be marketing in a way that is deceptive, right? They should not be pushing off-label use of their medication so that people might actually buy more of it, but they're buying it for a purpose that it's not really made for, and so on. Another way they can engage in transparent marketing is they could perhaps market a low dose of their drug for treating a disease when really people need a higher dose. So people might buy it thinking that they're getting an effective dosage when in fact they've been deceived and they're paying less money but not actually getting what they need. All right, so those are just some thoughts regarding transparent marketing. Anti-bribery and anti-corruption are fairly standard. The company should have policies in place so that their managers don't go about engaging in bribery of politicians or other people who have power in these countries who can decrease the access to medicines that the public has in these countries. All right, and also the company shouldn't support anti-competitive policies and practices. Okay, let's talk some about patents and licensing. So you should have some idea of what TRIPS is, and in particular, you should be aware that the Doha Declaration modified TRIPS. So TRIPS is an agreement by a number of countries, and most countries at this point are adhering to TRIP. The TRIPS arose from the World Trade Organization. It's a trade agreement. It's called the Trade-Related, or it stands for, Trade-Related Aspects of Intellectual Property Rights. So it's just a nice little acronym. And the TRIPS agreement really focuses on this notion that every country will offer intellectual property protection, and that they will offer patents on different goods that are created, that are novel and so on, meet certain patent standards for a minimum of 20 years. They can offer it for longer, but at least 20 years. So this is where the 20-year patent comes from. It comes from an agreement among countries indicating that they're going to protect property in this way. Now, this agreement occurred in 1994, so just realize that a lot of countries are fairly new to a patent process. India didn't develop theirs until 2005. So we have countries that are really sort of still getting up to speed, and we're still really feeling the benefits of the TRIPS agreement in some countries. Now, the Doha Declaration, sorry, which would happen in Doha, Qatar, um, took place in 2001, and what this declaration does is it points out that there are certain situations where a patent can actually be harmful to society. So, if you patent drugs that people really need, you're going to create a monopoly for a company, and then they're going to sell their drug at an extremely high price, and some people aren't going to be able to access the drug. So what does that mean? That means these individuals are going to go without a drug that they need. That can lead to worse health outcomes. It can lead to death for some people, and in particular, there are diseases like HIV/AIDS that are killing populations, and for certain populations that have really high rates of HIV/AIDS, drugs really matter. And if people are able to receive the drugs they need, then the entire face of the country can change, right? And this is the case for a number of conditions, primarily infections. So the Doha Declaration was basically a statement indicating that there are situations like this where countries can ask pharmaceutical companies, other types of companies that may be producing products that impact the public health, to lower their patent protections, right? And this was targeting mainly HIV/AIDS drugs so that countries can really gain access to HIV/AIDS drugs. And so now countries can use something called a compulsory license, which is a mechanism for forcing a pharmaceutical company to license its patent to other generic manufacturers who want to make its drug. What usually happens is that the country will request that the pharmaceutical company offer this patent based on this compulsory license. The country will say that it needs the drug because it has a crisis, a healthcare crisis, or a disease epidemic that needs attention and needs this particular drug. And without the drug, people are going to keep dying. So they then tell the company that they want to enforce a compulsory license using the Doha Declaration. Now, most companies are not going to be excited about this kind of request. The companies would prefer a voluntary license, right? So, a compulsory license means you're forcing these companies to do something. So, you couldn't come to an agreement that was voluntary, so you went the compulsory route. And companies kind of do this reluctantly. They really don't want to take this approach, and they prefer a model that allows them to make more money. Usually, compulsory licenses end up really not helping they end up not allowing the company to make much money. Now, there are exceptions to this. So the company could own a generic company, and that generic company could be one of the many companies manufacturing the drug. So the company could still make money off of the compulsory license, but they wouldn't make as much as if they were selling it on their own, and they wouldn't make as much as if they had a voluntary license. Companies voluntarily license patents all the time, and they are allowing some other company to make a product that they've created, right? That happens in a variety of different industries, right? That's how many companies make money off of their patents. They go around and they license it to different manufacturers, and those manufacturers make their products. That's one of the many ways that you can make money off of a patent. But for these compulsory licenses, this is now a country really forcing you to make your patent accessible to other generic companies. Now, realize that these generic companies are still making money off of the drug. It's not like the company is agreeing to the compulsory license, and then those who get the patent and start manufacturing the drug, it's not as though they do it for free, right? These companies that are generic companies, and as you know from the reading, most of them are in India. They are making money off these drugs. They're selling the drugs too, so they're not giving the drug away. They're just selling it at a much cheaper price than a brand name company would. So a brand name company would it would be advantageous for a brand name company to come up with other methods for getting their product out there and making money from it, other than handing over this license to other companies that are also going to make money. They're just going to charge less. But remember, most of the raw materials are coming from India and China. Um, and these companies, these countries, sorry, also have a lower cost for labor. So as a result, they can manufacture these drugs for a cheaper price, and the amount they're making, given the volume they're producing, might be a lot of money too. It might be somewhat similar to what the brand name company can make. It's just they're doing it in a different way. So this is not about these compulsory licenses are not resulting in completely free medications for people. There is some charge. It's going to be free, obviously, down the line for some really poor people who just have no money. But countries are paying for these, or NGOs may be paying for this money, these drugs, and so on. In the case of PEPFAR, which I'll talk about in a few minutes here, the U.S. government may be paying money for these drugs being manufactured in India, China, and other countries. These companies are getting money. The generic companies are getting money, and they are getting some benefits. So you can see why the larger brand name companies might have some objections to the compulsory licensing, because it's not all about charity. All right. And that's an important point for you to realize. Now, there's also this medicine patents pool. Um, a medicine patents pool is basically based on this principle that you take a bunch of patents for various drugs and you offer a combined license for these different drugs. So it's like going into a mall and picking out the patents you want and then paying all at once for a license for these patents. Now, that is a more efficient approach and may be much cheaper for a country to do versus going to each individual company trying to get a license from them. Just imagine this. That takes going to each individual country. Sorry, going to each individual company takes more time, more money, more energy, and you may not get a good deal. So the pool of patents that being pulled together by some organization, that's going to be offered at you for a price that you know. So you're going to be able to get this license for all these various patents for a price that you're aware of. So, for example, for HIV combination therapy, you can just go to a pool and say, well, we want this combination of drugs that we want to provide to our citizens as combination therapy, and we now don't have to go to all the different manufacturers that make each one of those drugs. We can just go to the patent pools and we can pay a certain fee to get the license, and the companies making the drugs also have to pay a royalty. So when they go off and make these drugs based on the license, and they sell it to people, they have to then push some of that money back to the pool. So then the pool gives some of that money back to the brand name manufacturer. All right. Hopefully that makes sense. So basically, all these patents are being pulled together. The rights to the patents are being sold as licenses, and a generic manufacturer will sell the drugs, and then when they get money back for selling those drugs, they'll push some of that money back to the patent pool, which then gives some of that money to the brand name manufacturers. So it's good for the brand name manufacturers because they know what kind of money they're going to get. They know it's their is, and so they know they have a better sense of their revenue than they do with all these individual licenses that they may have for countries. They also don't have to worry about the negotiating. The generic companies just come in and pick what they want. They don't have to worry about the negotiating. That's already been done, and they know how much they got to pay back and so on. So it's just a smoother transaction, and that can be a better approach than these individual licenses. All right, at this point, I think you're able to click on this link using YouTube. I think so. If not, you can just type in this YouTube address and take a look at the recent decision by the Indian Supreme Court, which focused on Gleevec. And their decision is that they did not grant a patent for the drug Gleevec, which is a cancer drug, because they didn't think the drug was innovative enough based on a prior patent. So the company had a prior patent, then they modified their drug a bit to create Gleevec, and they're claiming that it was innovative and novel. So it met our standards. It met the U.S. standards for getting a new patent. But India is saying it doesn't meet our standards. And so what we see happening in developing countries is we see them raising the bar for what innovation means. So this is a bottom line question for this area of policy: is what does innovation means, right? You had a few different definitions discussed in the reading that I gave you, the reading on the global pharmaceutical monopolies. Let me pull that up. The global politics of pharmaceutical monopoly power. So that reading, you can just go to the conclusions, chapter 8 there, and take a look at the discussion about different definitions of innovation. And you'll see that, for one, we really don't have one definition. And I would frankly argue that in the U.S. we're really not clear about what innovation means for drug companies. We basically let the USPTO tell us that something's new. And we have to ask, is that a good way to go? Because they're not looking at the outcome or the potential impact of the drug. All they're doing is looking to see if it's a slight chemical modification, if it looks novel, and so on. And that may not be good enough, right? So if your clinical trials show that your drug really is not doing as much as the past drug, and if your patent looks very similar to one of the current drugs you already have or some other drug out on the market, is it good enough to just sort of have marginal benefit? Do we need more than that? What are we calling innovative is the question. What is innovative here? Because anyone can string together, chemicals that are just changed a little bit and claim that it's innovative and new, but is it, right? And so we have to really hold countries more accountable. And so some countries are thinking about definitions of innovative that include access. So there's one commission, the WHO Commission on Intellectual Property, Innovation, and Public Health, that pointed out that the definition of innovation should include discovery, development, and delivery of the drug. So access is part of the definition. And so on the world stage, you have companies. Sorry, I said companies again. I mean countries that are actually focused on trying to change the definition of what we mean by innovative. And that's something moving forward that will be a question for us too. So instead of us getting a lot of Me Too drugs, if we pushed our companies a little bit on what's truly innovative before giving them this huge reward of a patent or market exclusivity from the FDA, then we might get better medicines. So just think more about that, and that's a potential way to perhaps improve the type of drugs that we're getting out on our system. And so this Indian Supreme Court decision may set a precedent, or maybe some other countries that end up having similar conclusions when it comes to thinking about what's innovative and what's not innovative, and we'll see moving forward. All right, so pharmaceutical monopoly power, we've already started talking about this. Anytime a company gets a patent for something, they have a monopoly, and the drug industry is no different. In fact, getting patents often leads to you getting venture capital money in our country. For those who are not aware, um, VCs, venture capital companies, love intellectual property because intellectual property does what? Blocks out your competition. So it's anti-competitive in some ways, right? It may be also anti-innovation, and there are some people who argue, especially libertarians, that patents actually slow down innovation because, for one, the company that has a patent is not incentivized to do anything else, right? They're just incentivized to rake in money for a few years, and then at some point they'll decide to engage in some innovation again, right? And then other companies that may be interested in innovating in this area may be afraid of being sued if they create a product that's too similar to the one that's already out there on the market that already has patent protection. So they have to worry about being sued because companies want to protect their monopoly power, right? So in some ways you could question whether or not patents are innovative, and you should think about, well, is there something different that we can do besides rewarding companies with patents, and we'll talk more about that. Um, Here are some of the other approaches that we can think about, and that your reading talks about, that are ways for us to award R&D, and ways for us to perhaps decrease the need for patents, or maybe push for shorter patents, or push for patents that are or have licenses attached to them. Okay, so one approach, as I say already, is just to change our definition of innovation. So we don't really have a good definition. The FDA doesn't necessarily have a good definition. They look at your clinical studies, and if you're able to prove that your product can do what you claim it can do, and you have a patent on it, and it's actually uh, your product is effective and safe, then you can get FDA approval. You can get exclusivity. If you already have a patent, you already have that market protection, and you're good to go. We really don't push companies that much when it comes to innovation. We like to see innovation, and the FDA definitely encourages innovation, but we don't really set a high bar for what we consider innovative. We don't. We don't look at Me Too drugs and say, well, that's just a copycat drug. You can't get you can't get patent protection for that, or we're not going to give you exclusivity, market exclusivity for that. And other countries are starting to say, well, maybe the U.S. is doing that wrong, and maybe that's one reason that the U.S. is paying so much for health care. All right. One of the alternative approaches talked about in your rating is license of right. This is a concept that is focused on adding a license to every patent that's produced. So when you grant a company a patent for their drug, you'll attach a license to it, so that any generic company that meets certain standards, you have certain standards for people to actually access these licenses, and once they meet those standards, they can actually get a license on the drug. So the idea here is that licenses are a part of the patenting process, so that we're not trying to block people from manufacturing the drug, but we also don't want to remove the protection that a company gets for actually engaging in innovation. So we give them some protection. We don't allow people to violate their patent per se, but what we do allow is for people to come in and meet certain standards and license the patent for a certain price and so on. And this would be a fairly automatic approach. We wouldn't have to worry about all the negotiating that might take place. You have a standard royalties that go with it and so on. Patent pools we already talked about. They're somewhat similar to this, except for they don't require that patents have a license attached to them. They're more voluntary, and so they're a grouping of patents that industry and companies are willing to place into the pools. Prizes is another way to go. So There are private funds out there that are used to engage in R&D. We have government funds that we use for research and development. Maybe we can come up with prizes for biomedical research, for clinical research, and so on. And this is nothing new. There are a variety of prizes already out there. We just don't have all of our R&D tied to different prizes. So what you would do with a prize is you would actually just pay for R&D. You would incentivize industry to accomplish some task, and then you would pay them for accomplishing the task, right? You say, well, here you go, here's the prize, you're number one, you actually did it, you solved the problem, and now you get your money for that R&D. So then if you go off and make the drug, we would think that you wouldn't need to charge so much because you'd already have the R&D costs paid for. Another approach is not-for-profit drug development. So you can have a not-for-profit that actually invests the money using its donor funds in R&D. So often what happens is there's some not-for-profit that um, wants to focus on some particular neglected disease, and they put up money. They say, look, we're willing to pay a drug company to engage in the R&D necessary for developing a product for this particular illness. And once they pay for the R&D, they then pass the R&D over to generic companies so that they can manufacture the drug for a really low price and get it to the people who need it for a low price, right? Again, it's not for free, it's just for a low price. Another approach is they say, well, we're not going to get a patent on the drug at all, so they don't have to worry about all the licensing stuff. They just provide the, sorry, I just said that. There's a no patent approach. Then there's an approach where they can have a patent. So they can do the R&D and they can get a patent, but then they can license out the patent for a really low cost or no cost to generic drug manufacturers. So they can use an approach where they just hand over the R&D and let the companies go for it, or they can actually go about getting a patent for the drug and then just licensing the patent for a really low cost, because their whole point is they want drugs for particular neglected disease, and they want to treat individuals. They're not trying to. They're trying to increase access to drugs, not decrease access. All right. Um, Another approach is for government to prevent exclusive licensing of drugs. So some companies want to create licenses that are exclusive, so that they're the only. They become the only. Um, sorry, that they become the only supplier of this license and of this information. So what they end up doing is they say that our license is only for a particular company, and only this company can make our drug, can make the generic version of our drug. Well, what that does is it still blocks out competition, right? So if you only one generic manufacturer of the drug and not a variety of different manufacturers, then they can't lower the price as much, or they have no incentive to lower the price as much as if you have a number of different generic manufacturers. So removing exclusive licenses is one approach to go about finding a way to allow for government R&D to have a greater impact. So let's say that the government pays for the R&D, like sometimes NIH pays for phase 1 and phase 2 research, and we might say, well, when we pay for the research, or at least some part of it, then we should be getting something back in return. And one thing we could get back in return is there should be no exclusive licensing of the drug. Another thing we could get back in return is that we might actually just say, well, there should be a discount on the drug. So if American taxpayers have paid for the drug, then when it's sold to Medicare beneficiaries, then we should get a discount, right? So that the brand name price that people are buying for in the private sector should not be the price that we get on the public side. Or we might just say, well, we, the people, as the public, we should get a discount. And so your R&D costs are not as great as you're saying they are, a company, so we should have some kind of discount on the brand name drug. So there are a lot of different approaches to think about, and this is really a highly active and innovative area of policy for those who may be interested. All right, I gave you a reading that really pointed out how healthcare is perceived as a right based on certain treaties, and so not certain treaties. Actually, one treaty in particular that the reading pointed to, and that this treaty, the International Covenant on Economic, Social, and Cultural Rights, could be used as a source of policy for indicating that there should be a right to accessing medicine. So if there's a right to health, then part of health is getting people medications they need. So there should be a right to medicines. You should know that in the U.S. there is no right to health. There is no constitutional right to health. Constitution doesn't say anything like that. Some people try to argue that some provisions of the Constitution that talk about life are actually talking about health, but it's sort of a really um, an argument that's a bit of a stretch, and it is not that strong of an argument. So it doesn't really go very far, but the Constitution clearly doesn't point out that there is a right of health. Now, you could always modify the Constitution, and I think that's what, if I remember correctly, Massachusetts modified their Constitution when they prior to engaging in health reform. And you might argue that even though healthcare is not a right, we're getting to a point where it's going to look like healthcare is something that we as a country think should be available to all people, even if we don't state it in our Constitution. So we'll see moving forward whether we reach that point. But I just wanted you to know that this is yet another source of policy to support access to medicines. All right. So, what are various approaches that governments can use to increase access to medicines? Compulsory licenses under the Doha Declaration, as we talked about. Parallel importation is another thing that governments can do. Now, parallel importation just describes the notion that a country may already be importing a drug, but they may be paying a high price for it. They may be getting it from the brand name company. Now, what if the brand name company, based on a compulsory license, has to let manufacturers in India manufacture the drug? Well, in that case, there's going to be cheaper drug on the market, right? So a company, sorry, not company, a country might then pay for that cheaper version, so that they have parallel imports. They have the expensive version coming in, and they have the cheaper version coming in. And so that's one way that countries can get cheaper drugs. They may just be searching around for the best deal and importing drugs from a variety of different companies. All right. PEPFAR, again, you can click on this link. That should be available to you. It's just the PEPFAR main page. I think it's pepfar.gov. And you'll see a nice little video on what PEPFAR is and really what it's all about, and what this entire effort, this entire class here is all about. And that's really trying to get drugs to folks out there who really need them. It's a pure public health concern. An initiative. We're really trying to help people who need help. Of course, in parallel with getting drugs out to people, you want to really engage in good prevention of disease too. So, if we're doing a better job preventing HIV and AIDS, then that will slow down the demand for these drugs, and that will increase the need to access certain drugs. So that's another piece of the puzzle too, of course. All right. PEPFAR helps a variety of countries now, and it focuses mainly on HIV and AIDS treatment. It's really revolutionized primary care in a lot of countries because PEPFAR has focused on setting up networks of clinics that it can then use to get HIV drugs out to, and other technologies related to treating HIV to these various clinics. And as a result, these clinics have basically offered better access to care for a number of areas, especially rural areas, and a variety of countries, particularly African countries. And so now people are using these clinics for much more than HIV/AIDS treatment, and also because HIV/AIDS is now becoming more of a chronic illness because of the effectiveness of the drugs. Some people are actually getting other types of care from these clinics, like diabetes treatment or other types of treatment, hypertension treatment, and so on, because people are living longer and they're having other types of health problems beyond HIV and AIDS. All right. Now, one question that's raised on the ethical side for PEPFAR is, can we ever stop PEPFAR? So once you start giving out these drugs and paying for this care, can you just pull it out? And the answer seems to be no. It's generally not ethical to start treating someone, then stop them midstream. And also, the goodwill that comes from PEPFAR um, is generate. So much goodwill is being generated for the U.S. that it's probably not something we want to stop, because it really would piss a lot of people off, a lot of NGOs, and so on. So it's looking like we may be doing PEPFAR for a long time until we can slow down the number of new HIV/AIDS cases. And as you know, there's a worldwide effort to try to do that. All right. I gave you an article on pharmaceutical spending that pointed out that there's a growing amount of spending in emerging markets. So when we think about companies, I keep saying countries, companies fighting off compulsory licensing, this is what they're concerned about. They're concerned that they're being pushed to provide licenses for their drugs to these generic manufacturers in countries that are representative of their future profit margin, right? So they know that these countries have growing middle classes and that these countries have a growing GDP. For example, the richest person in the world is not from the U.S. anymore, right? The guy's in Mexico. So that tells you that, look, there's a lot of money out there in these countries. The issue is that the money is not being distributed well to poor people. Now, you have to ask, is that the fault of our pharmaceutical companies? So now, because of poor distribution of wealth, should we now just kick in and give these countries a lot things at low cost and let them violate our patents and so on, take advantage of our intellectual property and the ideas and all the hard work that we put into creating these new products? Well, I think it's a tough argument. Obviously, that's a fairly conservative view of this issue. But you got to think about it. You got to look at this from a balanced point of view, and you can see why some companies have trouble with this notion that they're going to offer a compulsory license to a place that has a growing economy, has more and more people who can afford these products, and they're going to make money off of the drug when they sell it. They're just going to sell it for a lower price, but they're still going to make money off of it. So, compulsory licensing can really be a tool for these countries to actually just get even more money and have the economies grow even more. Many of the economies of growing nations, the nations of growing economies, like Brazil, Russia, India, and China, really want to get into the pharmaceutical market, and they really want to increase their market share. And they see graphs like this, and they know they're going to have more and more of the patients who need these drugs moving forward. So they want to make the money off of these consumers. They don't want U.S. companies shipping their drugs over, making all the money. So some of this is about capitalism and not just about getting access to medications. A lot of this money that's being going to these pharmaceutical companies is not necessarily getting to poor people. Now, it does stimulate the economies in these countries, so overall the condition is improving. But still, you have to realize that rich people are benefiting as a result too. They own these pharmaceutical companies. So just be aware that there's a shift, and over time, looks like after 2016, we're going to see emerging markets are really going to make up the bulk of not the bulk, but they're going to make up a larger percentage of the drug spending in the world than the U.S. at least. But developed, industrialized countries will still be at higher than emerging markets. But over time, these emerging markets, because they have more people, will overtake the industrialized nations that have fewer people. And if their economies keep improving and their middle classes keep growing, they're going to have more chronic diseases and so on because they're living longer, and so they're going to need more drugs. So that means they're going to be a bigger share of who's buying drugs around the world compared to the smaller industrialized countries out there. All right, so that's a trend that will happen moving forward. Now, I just briefly wanted to point out that patients can engage in efforts like protests and so on to increase access to drugs. And while protests for better, you may think are may not be that effective. In some cases they are effective, and when the public gets together in a unified way, they can get things done. If they really want access to certain medications and they push for it, they can usually get access to that medication. But they really got to work together. NGOs play a role, non governmental organizations, not for profits, play a role here in helping people get organized and fight. And in fact, for that Indian Supreme Court case, which hopefully you looked at, um, um, an organization like Doctors Without Borders was involved. So, and there's some other patient advocate type organizations that were involved in really pushing for this medication to be accessible and for the patent to not be a patent to not be granted in India and not be recognized in India for this particular drug. So there is some power for the patients out there, and they still have some power and they can really push and get the products they want if they work together. Divided, they can't do much, but when united, they can be extremely powerful and forceful. All right, so I just wanted to just quickly remind you that in the U.S. We have a variety of different approaches that we use to increase access to medicines, most of which we've already talked about in this class. So, various insurance mechanisms really do increase access to medications. And we know that Medicaid expansion and health insurance exchanges in 2014 are going to now increase access to medications. So these are, again, robust policies that we have in place. And in other nations, the tax structure is not there to create these kind of programs, and the countries again, the countries don't have the wealth that's necessary to provide insurance to the public in this way. But moving forward, some of these countries will have more money and they will be able to come up with unique approaches like this. All right. Now, one thing I haven't said a lot about in the class is patient assistance programs. So, patient assistance programs are really programs set up by companies to provide access to their drugs for free, usually. Some of them might offer it for low cost, but usually it's for free. And basically, what happens is a person can go fill out the paperwork for a patient assistance program and indicate that they cannot afford the drug. Usually, it's people who are very low income, but they're probably not on Medicaid, and so they're kind of in this gap. And they just can't pay for the drug. It's just too costly. Maybe some expensive biologic drug, a cancer drug, or so on. So a physician may help them with the paperwork and really help them make this claim that they need this drug but they can't afford it, and they will suffer without the drug. So the company will then evaluate whether that's true or not, and they will actually provide the drug for free. And remember, many of the companies already hand out free samples for drugs, so it's not really that harmful for them to have a patient assistance program and give the drug out for free. And also, not that many people use the patient assistance programs because many of them don't know about it, and there's a lot of paperwork involved, so many doctors avoid utilizing those programs and so on. All right. NGO approaches. I just wanted to point out that NGOs definitely have a role here. There's Gates Foundation that's out there. There are a number of other organizations that set up healthcare clinics that offer access to various medications and all kinds of things that NGOs can do. And they traditionally have been obviously big players in this arena, and they will continue to be a major force in this arena, even with things like the Doha Declaration around. You got to have NGOs and charitable organizations that are really working to help people throughout the world. All right, I want to mention one really innovative approach by one NGO that is attempting to utilize Coca-Cola's distribution network to provide access to oral rehydration therapy. So basically, there was this guy who volunteered in an African country. I don't have the country at my fingertips. I'm not sure which country he volunteered in. But he was basically impressed by the idea that despite the fact that people didn't have medications, they actually had Coca Cola. And he's like, how in the world is it that these people are getting access to Coke? And he just thought, well, maybe there's something we can learn from Coca Cola. Maybe Coca Cola is the answer to distributing medications and drugs and so on. So he thought initially that, well, maybe what I'll try to do is bargain with Coca Cola and let them stick my oral rehydration therapy into their Coke crates. Um, that turned out not to work, but what Coke did decide to do is to provide advice on their infrastructure and how they actually go about distributing their product to these various places. And as many of you know, Coke is all around the world, even in the poorest villages in African, South American countries, and so on. You can find Coke. And they translate into all a variety of different languages and so on. So they do all the things that we know in the public health community is going to work to get your product out, but they also do some things that the public health community doesn't do. For example, they actually charge for their product. Go figure, right? So what does that do? That generates value, right? And what does that do? Also for the economy, that generates jobs. So when people know they're carrying around this valuable product that people are willing to pay for, then you can stimulate more innovation. You can stimulate people to actually get involved. So Coke does things like they pay these small store owners incentives to get more product out. They have all kinds of distribution networks that they've set up where they get the Coke to wholesalers, but then they do creative things to get it out to these smaller players. They even have distribution that involves bicycles, right? So in some parts of the world, you just can't get around by car only, or people don't have enough money for cars, but they do have a bike. They have something, right? So just realizing that people have something and people are willing to pay a price. So maybe the Coke doesn't cost what it costs in the U.S., but it's they can find a price that people are willing to pay and actually charge it to them. So we always have to remember that although people are poor, they have some money. So sometimes adding value to something and demonstrating to them that it's worth money and worth something is a good way to have them actually purchase it, and it gets them involved in the distribution of it because they think that, well, I see that I pay money for that product. Somebody else is getting money for it, and maybe I can get involved in the selling of that product. And so Coke is one of the many products that you might see in rural villages throughout the world. And we can probably learn a lot from private companies with regards to their distribution networks and trying to make drugs more accessible. So it's just a really nice, clever example of how you can be innovative in this field. And we should always, as I've said before, try to utilize the private sector's innovation to improve the approaches that we have in the public health sector. So with that, I'm finished. Congrats to all who actually sat here and listened to the entire lecture without taking a break to get some pizza or so on. And I hope you have a great weekend. And ask me any questions you have by email, or ask me questions next week when I see you in class. Take care. Thanks.